and welcome to this talk on the cost effectiveness of major system change in specialist cancer surgery services in London. My name is Clarke and I'm a health economist at UCL. These are my co-authors along the bottom of the slide here from various academic and healthcare institutions in London, Manchester and Cambridge. And we're very grateful to the conference organisers for allowing us this opportunity to tell you about our work. This analysis comes from the Respect21 mixed method study, which started in about 2015 and is just finished, and we're in the process of publishing and disseminating the rest of our results. The project looked at major system change that was happening in part of London and in Greater Manchester, where some specialist cancer surgery services were being centralised. The cost effectiveness analysis, and therefore this talk, focuses on the London changes due to delays with the Manchester reconfigurations. So London Cancer was the name of a networked cancer system that covers a population of 3.2 million people across North Central and North East London and West Essex. The changes that we analysed in this project were centralisations, where specialist surgeries were moved so that instead of taking place across many sites, they instead took place at fewer sites, as this has been found to improve patient outcomes. The changes that happened were that for prostate and bladder, they moved from 4 sites to 1. For renal, they moved from 9 sites to 1. And for OG, they moved from 3 sites to 2. So the Respect21 mixed method study looked at a number of different areas, and the overall aims of the project were to qualitatively evaluate the processes of major system change. Then there were 2 quantitative streams which evaluated the impact of the reconfigurations on patient outcomes, so mortality and things like readmission to hospital after surgery. And the area that Rachel Hunter and I focused on as the health economists was evaluating the costs and the cost effectiveness of the reconfigurations. And finally, we pulled all of this together to consider how the lesson learned could apply in future centralisations. The reference on the bottom of the slide there is for our protocol paper, and there's been a number of other papers published so far. Please see our website. So for the cost effectiveness analysis, the aim was to evaluate whether the London cancer reconfigurations were cost effective. In order to do this, we calculated the costs and outcomes for these 4 groups of patients. So that's patients receiving surgery in the London cancer region before the changes, then patients receiving surgery in the London cancer region after the changes, and then the same pair of before and after groups, but in the rest of England outside London cancer area. We used the costs and outcomes information from these 4 groups to calculate the net monetary benefit in the London cancer area for each of the 4 cancers, using the rest of England data to control for other changes that might have happened at the same time. For example, if there's some national trend, then that would also show up in the rest of England data. So we can use that data as a kind of control to separate out the effect of just the reconfiguration. So that's the method that I've just described, the difference in differences analysis, where we look at before and after groups in London cancer and elsewhere. And this allows us to come up with a single answer for the impact of just the reconfiguration itself in the London cancer area. We also adjusted for some baseline patient and disease characteristics. We used routine patient level data for this, which I'll describe a bit more on the next slide. And the costs that we calculated were costs to the NHS based on hospital resource use. The outcomes were quality adjusted life years, or QALYs. You calculate QALYs by capturing quality of life data at different time points, and you calculate the area under the curve that's described by this quality of life information over a period of time. And the area is the number of QALYs. In this analysis, we didn't have any direct quality of life data, as this is not routinely recorded in hospitals for cancer, so we had to make some assumptions here. The patient level data that we used started with identification of patients in cancer registry data. So we asked for all of the data on all of the patients who had been diagnosed with one of our 4 cancers during the time period that we were looking at, which was from the 1st of January 2012 to the end of December 2017. We asked for this registry information to then be linked by patient to the hospital data and to mortality data. And then this linked data set was sent to us and we analysed it. So the before and after groups that I talked about for the difference in differences analysis were defined by the dates that you can see in the table here. And this means patients that were diagnosed before or after the reconfiguration had happened. So I'll run through prostate as an example. If we look at the top line of the table, we can see that for prostate cancer, the before groups were patients who had a diagnosis of prostate cancer between the 1st of January 2012 and the 1st of July 2015. And the after groups were patients who were diagnosed between the 1st of April 2016 and the end of December 2017. Then there's this grey area in the middle, which was when the reconfiguration of prostate specialist cancer surgery services had started but not finished. So some patients were seen under the old pathway and some were seen under the new pathway. Similarly for bladder and renal. For OG, it's slightly different because it was a simpler move from 3 sites to 2 sites, and it all happened pretty much on one day, so there's no during period for OG. The cost effectiveness analysis involved calculating costs and QALYs for the patients in our data set, and the way we did this was to use a short-term model and then a longer-term model. The short-term model was a decision tree where patients entered the model on their surgery date, and then at the end of 30 days, we looked at whether they'd had any readmissions, and they were classified as healthy if they'd not had a readmission, and not healthy if they had had a readmission in that 30-day period. For prostate, we used 90 days, and we also included length of stay for prostate. So people would be classified as not healthy if they'd either had a readmission within 90 days after surgery, or if their stay in hospital for the initial surgery had been longer than 3 days, or both. Then the longer term part of the model came after the decision tree, and this is where we looked at mortality rates. And we extended this out to 10 years to hopefully capture all the relevant costs and outcomes, and to have a standard time horizon across the 4 cancers. When we added up all the costs for people across the short-term and longer-term parts of the model, we also included at the very beginning the costs of designing, planning, and implementing the reconfigurations. So I presented this work at this conference last year, and the paper has just been published in the Journal for Applied Health Economics and Health Policy, and the reference for that paper is on the bottom of the slide there. We calculated per person costs to add into the models using the annual incidence of each of the 4 cancers in the London area. You can see here that the prostate cancer group has a higher annual number of new patients than the other 3 cancers, and this will be important when we're looking at the results on the next slide. So this is a summary of the overall results. We found that the reconfiguration was cost effective for prostate cancer, but for the other 3, it was less clear. There were fewer patients for the other 3 cancers, which didn't help, and the mortality rates for all 4 of them were fairly low, which means that there were not large numbers of death events to base the analysis on. For the short-term decision tree part of the model for each cancer, we separated patients into 3 groups, healthy, not healthy, and dead, that I explained earlier on. And that meant that these small patient numbers got even smaller at that stage of the model. Although we did the 4 analyses separately for the 4 cancers, they do kind of come as a group because the clinical pathways overlap, especially in urology. So we would not be able to say that the prostate changes would give the same result if that change had been made entirely alone without the other changes. So this is quite a busy table, sorry about that. But it just shows the final results for the costs and QALYs. The top bit with the red background shows the mean costs per patient over the 10-year time horizon of the model for each of the 4 cancers, adjusted for the baseline characteristics that I showed on slide 4, and discounted in the standard economic way for future cost and QALYs over the 10-year time horizon of the model. We can see that for the 4 cancers, the differences in mean costs per patient in the London cancer region and across the rest of England were either positive, i.e. costs increased, or there was not a significant change. If we look now at the difference in differences line for prostate, for example, we can see that in the rest of England, the cost increase was bigger than in the London cancer area, meaning that the difference in differences tells us that the London cancer reconfiguration resulted in a relative drop in costs. The reason why I've highlighted the prostate column is because the other cancers' results must be taken with a pinch of salt due to small patient and event numbers. I won't talk through the QALY rows. The logic of looking at that information is the same as for the costs, but I will talk about the bottom of the table, as this shows the final economic result which is the likelihood of the reconfigurations being cost effective for each of the 4 cancers at standard cost effectiveness threshold. And you can see that prostate is very likely to be cost effective at over 90%, regardless of which threshold you're using. But for the others, it's less clear. The reason why we use likelihood for our final result is because we're combining the results for the cost and quality together to give the final economic result. And the statistical methods around significance levels that we use don't work so well for this combination. So we use economic methods that talk about likelihood. So the other 3 cancers appear less likely to be cost effective, but we can't definitively say that they were not cost effective because of the analysis having been based on small patient numbers and small event numbers. So there are, of course, limitations to this analysis. Firstly, the small patient numbers and small event numbers that I keep mentioning, which meant that it was quite difficult to get a clear answer for the bladder, renal and OD cancers. We also based our costs on just hospital data, so we didn't have anything on primary care or community care. We had to make a number of assumptions. We used the difference in differences method because this is not a randomized situation. So we use difference in differences to account for bias, where normally you would use randomization to try and remove bias, but you need a different technique if you can't randomize. Also, the definition of the health states at the end of the decision tree was based on treatments observed in routine data, which is not ideal, but it's the best that we could do. We had to use quality of life scores from literature and approximate them to the patients in our data set. And the survival models were, again, an approximation and not perfect. We did control for certain baseline and disease characteristics, but there could have been other things that we didn't have. So the implications of the analysis overall are that reconfiguration can be worthwhile in cost effectiveness terms, even when you do include these implementation costs. And finally, although we couldn't say that the reconfigurations were cost effective for bladder, renal and OD, equally we couldn't conclusively say that they were not. So thank you very much for listening. If you have any questions or comments, please do get in touch. And please do drop me a line if you'd like to be put on the mailing list for our short course that we'll be running later this year, aimed at trialists and trial teams. Thank you very much. I hope you enjoy the conference.